Extra payments are due to policies adopted from 97 to 2003, and this is obviously with the Republican majority in the Congress. Before that, starting in 1992, under a Reagan administration proposal, plans were paid 95% of fee-for-service cost in each of the 3,000 counties. So fee-for-service costs in the counties were the point of reference from 92 up to 97. In 97, the Senate, which many of you know is very rural-oriented, and previously had paid hospitals more than the DRG system would suggest, or paid rural physicians more than the Medicare RBRVS system suggested, that the Republican majority then decided in 1997 to pay plans in rural areas more than the 95% of cost. So that was the first step to ever pay plans more than fee-for-service costs in the county. That was extended in 2000. If you remember 2000, there were big surpluses. People were trying to figure out what to do with the surpluses. So in addition to rural areas, new floors or payments in addition to 100% were provided in 2000. And then finally in 2003, with the $400 billion for the drug bill, some of that was actually used to pay all plans, Medicare Advantage plans in all counties in the country, more than 100% of fee-for-service. So that's really the history. Before 97, it was 95%, but these are policies that were added again in 97, 2000, and 2003. There have been, since 2003, there have been some small policies adopted which begin to go in the other direction. And I think that does indicate some sense that the policies here went too far, particularly phase out of budget neutral payments. These are some technical payments, indirect medical education double payments, and of course perhaps most importantly the elimination of private fee-for-service plans in the larger counties with two other plans. So there have been important changes which indicate that this enthusiasm has really peaked, and some reductions in recent years, mostly as the pay-for the Medicare physician payment, the so-called SGR fix. So when funds were needed to make legislation budget neutral, people recognized these extra payments as an obvious source. Here's the extra payments, and the one thing I want to point out here is we hear so much about rural. Again, it all began with the rural floors in 97. Here we see of the $11 billion, only 11% of that $11 billion is for rural floors. 53% are the urban, mostly small urban areas, and 53% of the 11 is for urban areas. And then because of some very specific provisions, we could talk about the 100% fee-for-service counties are not paid 100% fee-for-service, but they're actually paid more than fee-for-service, and again, that's 30% of the $11 billion. So those are the sort of range. They're very complicated and a whole series of policies adopted in these different years. If we look then to say, okay, there's $11 billion in 1 year, $150 billion, and I think again we should note, just as the previous reductions were related to the pay-fors for fixing the Medicare physician SGR, that this is really the pay-for as part for health care reform. And I think without the need for the pay-for, the budget neutrality, probably much of this discussion wouldn't be occurring. But there are really four options. The most obvious is to take the plans back not to 95%, but to 100% of fee-for-service cost in each county. And that is, as indicated, what the House did 2 years ago. On the other hand, there are other approaches which actually don't take each county to 100%. Two of these were requested and have been studied by MedPAC: 75-25% blend of local and national costs, regional average of fee-for-service costs, metro-wide regions, and a bid-based payment system, again suggested by the administration. If we look at the overall impact, all options would pay close to 100% fee-for-service on the national average. And obviously, if you pay at 100% at the county average, every county plan, every plan in every county is paid at 100% of costs in that county. So that approach pays all counties. On the other hand, the other approach is the 75-25 blend, a regional blend, or a bid-based, pay some plans less, and in some cases much less than 100% in their counties, to cross-subsidize plans in other counties which would remain to be paid substantially more than fee-for-service. So the question then is whether it's best to pay plans all the same, reflecting costs in their county, which is where their markets, where they're contracting with hospital doctors, or whether some plans should be paid less so other plans and other counties can be paid more.